a presentation from one of our colleagues, Barwakha Ahmed. She's a level 5 medical student, and she's going to present a case on childhood pneumonia, pediatrics. We are also very much honored to have with us today Dr. Adil Waris. Dr. Adil Waris is a consultant pediatric pulmonologist and also a lecturer at the University of Nairobi and Aga Khan University for 17 years. We are very much honored to actually have him with us today out of his very busy schedule. And we really appreciate you, Dr. for making time and also guiding us also in the preparation for the topic. Before we start, I want to ask Barwakha, are you in? Just to confirm.
Yes, I'm in.
Okay, I'll make you a co-host. Kindly, you can go ahead and actually start sharing your screen. Welcome. Dr. Karibu sana. Maybe we want to start with the what before we start?
Jazakallah. This is what I'm suggesting as Daktari does her presentation. I always feel that when it comes to knowledge and education, the aim should not be to finish Barwakha's presentation. The aim should be to learn as we go along. So if it is possible, as colleagues have questions as we go along, do not save them till the end. Let's have the questions as we go along, and maybe they can be put into the chat box, and maybe you can also read them out, and we can stop every couple of slides and go through those questions wherever they are pertinent. And another thing is that if you don't mind, I'll also be asking colleagues questions as we go along, just so that we share and we learn together. So if I pick your name and we want to have a discussion with you, please do not be shy, because we learn from each other and I also learn from you. With that, Barwakha, can you start? Bismillah.
Is my screen visible?
Yes, go ahead.
Okay. I'm presenting HT 3 years.
Sorry, Barwakha, could you kindly put it on slideshow before we start? Thank you.
And Barwakha, I will be interrupting you very many times, and I hope you do not mind.
It's okay, Doc. So I'm presenting HT, 3 years old and 9 months, male, resides in Kikuyu. They were admitted 15 days ago. The informant mother is Mariam. Presenting complaint, hotness of body for 17 days, chest pain for 17 days, difficulty in breathing for 17 days. History of presenting illness, the patient was last well 17 days ago when he developed hotness of body. It was sudden in onset, continuous and persistent in nature, of moderate grade, relieved on administration of Brustan. Mother reports that the child could not sleep well due to hotness of body. It was associated with palpitation and loss of appetite, as the mother reports. There was positive history of contact with person with chronic cough. That was the maternal grandmother. No history of night sweats, lethargy or traveling, no weight loss. No history of convulsions as well. In addition to the hotness of body, the patient also experienced chest pain, which was sudden in onset and was on the right side. It was associated with mild dry cough, exacerbated by breathing in and relieved on leaning on the right side. No history of wheeze. There was history of difficulty in breathing for 17 days, associated with inability to do normal activity like going to the toilet. The child was being carried by the mother, and I graded that grade 4 in the New York Heart Association. It was associated with orthopnea, however, no association with paroxysmal nocturnal dizziness, nor fatigue. He was first seen at Kikuyu Hospital for 6 days.
I'll just stop you there, Dr. Are you moving your slides? Because I only see the biodata.
Yeah, I'm moving actually.
Are the rest of the colleagues seeing the slides moving? I'm not seeing any movement.
Not moving.
Actually, no. Barwakha.
Yes.
I thought I was the only one. Can we share the entire screen on slideshow? Sorry. You can enable editing at the top, then you put it on slideshow, please.
Are you able to see?
It's still not on slideshow, sorry.
Let me stop sharing.
Whilst Daktari is sharing the slides, does anybody have something to say about chest pain and childhood pneumonia? What does that tell somebody? I don't really want to pick names. Can a colleague tell us what they think? Mohammed, are colleagues able to just unmute themselves and answer, or it's not possible?
Yes, they can. They're able to.
So without me picking a name, can somebody suggest what they think about chest pain?
And now?
Yeah, perfect now, Barwakha.
Okay. It's moving?
Yes, it is. Just leave it on this slide, biodata, the next one, Barwakha. Just so that colleagues get into the, yeah, let's leave it here for now. Colleagues, tell us what you think about chest pain. The more you engage, the more we can have a conversation.
Dr. Adil, can you hear me?
Yes.
Please. When you hear chest pain and difficulty in breathing, so many things will come to your mind, and then first on top of your list will be pneumonia was one of them, and then another one will be more of like a bronchiolitis.
Tell me something. Do you hear children complaining of chest pain very commonly when they're having pneumonia and bronchiolitis?
There will be difficulty in breathing. Eh?
True, Daktari. And chest pain, rare, isn't it?
Yeah, it's rare, but they may be also, although it's not specific to there may be aspect of a cardiac issue maybe as well.
Okay. So and thank you so much, Daktari, for volunteering and putting your thoughts out there. This is the first flag in this child. It's very rare to get chest pain in 3-year-old children or them holding one side of their body. So yes, Daktari here is sharing what she believes is pneumonia, but that's the first red flag we're going to share today. Barwakha, just show me the next slide.
Okay.
So Brufen could not sleep well, hotness of body, positive contact. Let's talk a little bit about positive contact, Barwakha. This is now to you. Okay. Exactly how positive was this positive contact?
Okay, the grandmother was staying with the kid and the maternal mother also in the same house. Like she was coughing for a while.
How long is a while, Barwakha?
Like a month.
And what was her ultimate and final diagnosis?
They didn't have, the mother said she can't really know the exact diagnosis, but she was really coughing for a while.
Okay, so here is a few thoughts that I feel as a family of colleagues we need to be aware of. If the maternal grandmother has had a cough for about a month, here are the questions I would want us to think about. And as undergrad students, postgrad students, and myself, I mean, it doesn't matter where you are in life, but this is important. Number one, does the grandmother stay in the same house as the child? Number two, is the grandmother just visiting over Saturday and Sunday? Number three, is the grandmother sleeping in the same room as the child? Number four, has this grandmother been coughing for maybe 1.5 years? And that is chronic cough. Because you see, any grandmother who's coughing for 1.5 years almost definitely does not have TB, because you're not going to have a grandparent who has tuberculosis for 15 months and she's still alive. Sorry for the choice of words there. The next point you need to talk about when you're having a history of chronic cough is, say, for example, Barwakha, you see this mother, the grandmother, she was coughing and then the cough went away after a month. Yet you and I know that in tuberculosis, if the grandmother had TB, it would be very unlikely that the cough would go away in a 70-something-year-old lady. You get my point, Barwakha?
Yes, Doc.
So this positive history of contact with chronic cough has to be substantiated, that there was somebody who coughed, but the cough self-resolved, because that means something to a medical worker. Remember that when we're doing a history, we're not just regurgitating what parents tell us. We are synthesizing information that they've given us that sounds credible and useful to us. So just because the mother says it doesn't necessarily mean we have to report it, but we have to synthesize that information. I hope that point is clear, Barwakha.
Yes, doctor.
And Barwakha, please remember, this is not about you and me. It is not personal. You're the one who's on the hot spot today, but it is all about learning. There is no ill intent from these questions and answers. We are clear?
Yes, doc.
Okay, move to the next slide, please. Okay, hotness of body, chest pain, breathing, no history of wheeze. Okay, I think this one you told us nicely. Next slide, please. Okay, now take over, Daktari.
Okay. He was first seen in Kikuyu Hospital for 6 days, where he was managed with IV ceftriaxone 600 mg OD, amoxiclav 600 mg TDS, gentamicin 150 mg OD, and Brustan 10 ml.
Okay, stop right there. I want any colleague listening to me right now to comment on the choice of antibiotics given to this patient. Let's have some participation. Colleagues, please.
I believe the first-line treatment for pneumonia should not start with IV ceftriaxone, amoxiclav, and gentamicin.
So then what would you want to work with?
Amoxicillin and gentamicin.
Why are you using? Now, who am I speaking to? In fact, if you give me your names, it'll make life so interesting. Who is that?
Hamza.
Okay, don't unmute yourselves. I mean, stay on unmute so that we can have a conversation. Tell me again your choice of antibiotic.
For first-line treatment, you do go for amoxicillin and gentamicin.
Why are you adding the gentamicin, Hamza?
For gram-negative.
Which gram-negative are you aiming to treat?
I'm not sure on that.
What is the commonest cause of pneumonia in children, Hamza?
Strep pneumo.
And what would be the most useful antibiotic to give for strep pneumo?
Amoxicillin and gentamicin. I'm really not sure.
The beauty, Hamza, of being put on the spot is that once you get the answer, you will remember for the rest of your life. There's one of our colleagues who has posted, and I like the fact that you're also posting on the chat group. It makes this a little bit more useful. But Hamza, it's amoxicillin that one would want to work with. So you see here, when we're working with amoxicillin with clavulanic acid, we've already taken a step up too high. With gentamicin, Hamza, where you do have a point is maybe in children who are immunosuppressed, or those who are very, very young, or those who are on steroids or have oncological processes happening. That would be a useful addition. So that's where your thoughts are well-founded, Hamza. If you are dealing with patients who have a background degree of immunosuppression, you may want to strongly consider the gentamicin. So can another colleague tell me on the thoughts of ceftriaxone with amoxiclav, with gentamicin? What are your thoughts on triple antibiotics here? And maybe you can tell me your name and then you answer. Let's have a back and a forth, colleagues. Colleagues.
Doc, assalamu alaikum.
Assalam, tell me.
So I'm Sharif Ibrahim.
Yes, Sharif.
So according to the protocol that we used to have, that when you admit a patient for pneumonia, mostly you give amoxicillin plus gentamicin as an empiric treatment as you wait for the culture, so that and then maybe you can go for ceftriaxone or maybe you go for gentamicin.
So you agree in this particular case, Sharif, there's a multiplicity of antibiotic, correct?
Yeah.
Okay, thank you. Barwakha, if you can carry on.
Okay, 4 days post-admission, a chest X-ray was done, which revealed presence of pleural effusion, which resulted to his referral to Kenyatta National Hospital. On admission in KNH, they continued administration of ceftriaxone, and sputum test was done 2 days later to rule out TB, and the results were negative. 7 days ago, a repeat of chest X-ray was done, and it showed resolution.
Okay, stop then. Go back one slide, Barwakha. Okay, so colleagues, let me hear different voices and let's contribute. I wouldn't mind if you even put it in the chat box. So if you see this child now has an effusion, what's your most likely thought in terms of etiology? What microbial do you think we're dealing with now? Let me hear a voice, please. Colleagues, what bug do you think we're dealing with now?
So mostly this thing will be like strep. Because
yeah, carry on.
Seems like the patient had pneumonia. So most probably it's an exudative cause of pleural effusion. Mostly seems like a strep pneumonia.
Okay. Now, what would be your next most likely choice, Dr. Hari? Don't leave yet. So strep pneumonia is high up on your list. What would be number 2? Anyone wants to help, Dr. Hari? What do you think about Staph aureus, guys? Yes, thank you. Nasteha, Staph aureus. Now, Nasteha, come online, please. Nasteha Aji. You're right about your staph. So what antibiotic would you want, Nasteha?
Aminoglycosides.
Aminoglycosides. Do people agree? Aminoglycosides. Any other thoughts? Ceftriaxone, Abdirahman, vancomycin. The answer is still no. If it's Staph aureus, what is the most important antibiotic you'd want? Oxacillin, macrolide.
Third generation cephalosporin.
Maybe you can use halogenated penicillins.
Third generation penicillin. Sorry, I couldn't hear that last colleague. Flucloxacillin, Najma. Very good. Thank you.
Penicillin.
Now, let's stick with Najma. Now, this flucloxacillin, see, that's a useful idea. You know, the importance about thinking about flucloxacillin is that you also have an oral preparation available. The colleagues who said amikacin and what else? What are people talking about? I lost track in all those answers that came through. Vancomycin, sorry, is that you don't have an oral preparation. So the thing is that if you have a child hospitalized with a pleural effusion and you decide to put the child on aminoglycoside or vancomycin, you're now committed to keeping the child in hospital for at least 10 days with IV. Now, which one of us would want our children in a hospital for 10 days? And I can't remember now, Nasteha and Najma, who was suggesting flucloxacillin. Now, that's a very useful thought flow process because you start with IV fluclox, and as soon as you sort out the effusion, you can then move on to oral flucloxacillin. Yes, Bashir, linezolide also has a possibility because you also have an oral preparation. But remember, you don't go up too high, up the antibiotic bandwagon as well. Tell me, Nasteha, since you answered so correctly, what tests would you have done for the TB to show that they were negative or positive? Can Nasteha come online?
Yes, Doc, come again.
What tests would you do in this patient to rule out TB?
Gene expert. Some
Of which-
or analysis of the pleural effusion.
Okay, give me all the tests that you know that you would use for this child, Nasteha.
We'll do analysis of the pleural effusion.
Yeah.
Also hemogram, CRP.
No, but you see, hemogram and CRP are not going to be that specific. We are interested in tuberculosis. One of your colleagues has helped you and talked
Gene
about.
expert.
Very good. What else? What fluid? What body? Where would you want to get a sample from this patient, Nasteha?
Pleural tap.
Okay. And Hanif says also the sputum. Do you think that's a good idea, Nasteha?
I think since there's already an effusion, that will be the more accurate. But also gene expert still, the sputum will do.
Okay, so dear colleagues, so that we are together, Hanif is right, Nasteha is right. I would actually investigate this child from two avenues. I would do an induced sputum on this child, and I would also take a pleural tap. And then I would investigate for the following. And my dear colleagues, I would write this down if I were you. I would do 2 gene experts on either the sputum or the pleural fluid. I would do 2 ZN stains on the sputum and the pleural fluid. And I would do at least 2 or 3 TB cultures with sensitivities on the sputum and on the pleural fluid. You know, the thing is, dear colleagues, you don't ever want to miss tuberculosis in a patient who's got an effusion. So since we deal with paucibacillary disease, you need to maximize your yield from the pleural space. And you have to understand that if this child has tuberculosis, it went in via an aerosol. And so you would want to also investigate it from the sputum as well. One of the commonest causes of us not getting positives on our TB workup is because we don't get representative samples. And a lot of pleural effusions are also negative for gene experts, etc. Why too, Omar? And I love the fact that you're asking questions, colleagues. For the same reason that I've just mentioned, because the first pickup rate is between 30 to 60%, and then the second one increases your yield and your sensitivity of it. In fact, if you do 3, you will even, Omar, you will get even a better pickup rate. But studies have shown that the cost-benefit analysis does not, in public health, mandate you to do the third. I mean, by the time you do 2, you've actually done quite well. One day we really, I know today is a day about pneumonia, but one day we really need to talk about how to do a proper induced sputum or a gastric lavage and how to actually take the samples to the hospital. So that maybe Mohammed, who's coordinating and co-hosting, might think about it. Who is our presenter? The names are now confusing me. Can our presenter carry on? Barwakha, can you carry on? Barwakha, I'm sorry we're going to keep on interrupting you like this. I hope it's acceptable to you, my dear.
It's okay.
Okay, so KNH, ceftriaxone, TB. So we are hoping that you did some of those tests. We'll take your word and say that this child was TB negative. Carry on to the next slide, Dr.
Okay, review of the system, the other system like respiratory, cardiovascular, there were
Fine,
no.
let's go to the next slide.
Okay, past medical history. I think this is the second admission from Kikuyu. There was no positive findings.
We want to know about the first admission. When was this child admitted first?
Like 15, if I go back to the history, it was he was seen 6 days before he came here, like in Kenya.
Oh, the first hospitalization was 6 days before the current hospitalization.
Yeah.
So technically it was the same hospitalization. I mean, it's the same process the child was undergoing, correct, Barwakha?
Yes, doc.
Okay, my dear. Okay, carry on. And just to answer Hamza's question, when you're doing a test for tuberculosis, like in this patient, you do one at point of care. So when the child is in the ward, you do a sputum and you take the pleural tap, and then you would do it the following day, Hamza. It is good that you're asking questions. Your questions will generate more conversation. Barwakha, move to the next slide, please.
Antenatal history, the mother attended at Kikuyu Clinic where she went for 8 visits with her first visit at 3 weeks gestation. VDRL.
Let's move to the next slide. There's nothing here that's relevant, right? The only thing that I'm happy that you pointed out here is no history of smoking, because we know that if you're a smoker or you have a parent who's a smoker, or if you're using a lot of biomass fuels, then the chances of you getting pneumonias and severe pneumonias are higher. True, Barwakha?
Yeah, doc.
Now, I would like somebody who I've not heard to tell us why smoking increases your chances of getting pneumonias for children. If the parents smoke, why do the children get more pneumonia? Can I hear some thoughts? Colleagues, I won't move on. We need to learn this thing. Try one of you, please. Let's do this together. Okay, Hafsa, come online, Hafsa.
Yes.
Thank you for answering. Sorry to make you come on and pick on you. Tell me, how do you think smoking will get this 3-year-old to have more pneumonia?
I think if the parents are smoking in the house, the child can become a passive smoker and it's more dangerous because they're taking the waste products from like smoking itself is bad, but now the waste from smoking is what they're breathing in, I'm guessing.
But what is it doing pathophysiologically?
Not sure.
Anybody wants to try and help? This is a very important concept, colleagues. Whoever S is, come online.
Hello, I was guessing maybe the smoking will restrict the normal development of the baby's organs in the womb, so it will predispose the baby to more infections.
What does S stand for? What is your name?
My name is Suad.
Suad, stay online, Suad, okay, for a few minutes. I'm so happy that you've started by taking us to in utero, and that is what is very important. If a mother smokes, or even a grandparent has been smoking, the chances of you having a child who's going to have issues with the lungs and with lung development is much, much higher. Children who are born to mothers who smoke have smaller lungs, have poor mucociliary clearances, have poor cytokine expressions, have poor alveolar macrophage involvements dealing with pathogens, etc. I mean, the list is ever endless. There is more pulmonary hypertension. There is poor alveolarization and bronchial development of the lungs. I tell you, pretty much whatever you will say that happens in the lung maturity that is bad will most likely be correct if you have a mother who smokes whilst she was pregnant. Now, if the same mother smokes thereafter, or the father for that matter, again, the same problems occur in the growing child. So they have poor mucociliary function, they have poor cytokines and poor alveolar function, etc. So even this smoker's cough that you hear people having, it's because the mucociliary escalator is not working very well, and that gives you an increased amount of pneumonias in these children. Now, this is a Muslim Students Association generated Zoom link, whatever it is today. And there's something that in our community that we do that is very, very wrong. And I hope I don't get into a lot of trouble. But I'm sure a lot of you know what is oud. It is the bark of a tree that sometimes people choma in their houses so that their houses smell very nice, especially common in the Muslims of the Somali community. I mean no disrespect by this conversation, because we are all one. This is a biomass fuel that will only cause more irritant bronchitis and poor lung development. And as a community of medical professionals, this is something that I feel we need to share with the community and get them to stop oud. So even doing oud on Yawm al-Juma or whichever Yawm you want to discuss is not acceptable, and it's something that needs to be stopped. Barwakha, that is clear to you?
Yes, Doc.
Okay, I think we can move to your next slide. So it's not just smoking in the house, it's the use of biomass fuels. Huh?
Okay.
Carry on, Dr.
Birth history. The baby was delivered at gestation of 41 weeks and 4 days. The mother was 28 years of age, para 2+0. Mode of delivery was elective CS due to macrosomia at 3.9 kgs. Baby cried immediately and there was immediate initiation of breastfeeding. No postpartum complication in both the neonate and the mother. Growth and development history. Current weight was 18.9 kgs. Height was 99.5 centimeter. There was a normal growth. Developmental history, the gross fine motor and all language, social skills were adequately achieved with age. The child goes to school, is currently in reception, and his academic performance is good. Immunization history, mother reports that the child has received all the immunization as per KP. Nutritional history, the child was exclusively breastfed for 6 months and complementary feeding was introduced in 6 months.
Sorry, I'm so sorry. All vaccine, go back one slide. Mother reports that child has received all immunizations. Did you check?
Yeah.
You personally?
Yeah, the purple book.
You checked yourself and all the vaccines were up to date?
Yeah.
Okay, so remember synthesis of information. We will listen to what the parents have got to say, but we'll also check. So please remember, it's very important. I don't mean to say at an undergrad level. It's very important at all levels to check that the KP books have actually been filled.
Okay.
Carry on, Dr.
Nutritional history, the child was exclusively breastfed for 6 months and complementary feeding was introduced at 6 months. Patient was feeding well prior to symptoms and currently on normal adult diet. The 24-hour recall
Leave this slide. Let's move to the next one.
Okay. Family social history, the child is firstborn in a family of 2. They live in a 3-bedroom house with both his parents and a brother who is 1 year and 11 months.
Let's move to the next slide.
Okay. In summary, I'm presenting HT, 3 years old.
Next slide.
Okay.
Sorry,
it's okay, Doc. General examination. The child was in fair general condition, no features of respiratory distress, sitting upright on the bed with a cannula on the right hand. Nutritional status was well nourished. Anthropometry, history weight was 18.9 kgs, height 99.5 centimeter, mark was at 17 centimeter, head circumference 53.2 centimeter. All measures were within normal range. Vital signs.
Wait. You know, in your exam of life, it'll be nice for you to put maybe Z scores or something next to each one in particular. You know, in your exam, you know, each with the weight you put what you think was expected at that point, or what you think is the Z score. So,
okay.
All right, carry on.
The vital signs, temperature was at 36.3 degrees centigrade at that time of examination. Respiratory rate was 31 breaths per minute, which was normal. Pulse rate of 110. It was regular. Oxygen saturation was at 96% room air. Blood pressure was at 96/78 millimeters of mercury. And there was no scleral jaundice, no palmar or conjunctival lingual pallor, no central peripheral cyanosis, no finger clubbing, no lymphadenopathy, no edema, no features of dehydration. The capillary refill was less than 3 seconds and increased skin turgor. Examination of the ENT, the ear positioned centrally in proportion to the head, no drainage, no deformities, lesions, no attendance on palpation.
Give us the next slide.
Okay.
So this was all normal.
Yeah.
Yeah, let's come here now.
On inspection, respiratory system examination and inspection, there was no scar, no skin, hyper or hypopigmentation, presence of symmetrical chest wall movement. On palpitation, there was no tracheal deviation, no tenderness, no the presence of symmetrical chest expansion was equal. Percussion, there was dullness at the right, middle, and lower lobe. On auscultation, there was bronchial breath sounds, crackles, and wheeze on the right and middle, lower lobe.
Carry on.
Cardiovascular system on inspection, there was no hyperactive pericardium. Palpation, apex beat was at fourth intercostal space. Mid-clavicular line, no thrill, no heave, no tab. On auscultation, S1, S2 was heard, no added sound. CNS examination, the child was
Next
alert.
slide.
Okay. Abdominal, there was no positive finding also.
Okay. Next.
The definitive diagnosis here was severe pneumonia, stroke community-acquired pneumonia with lobar pneumonia with pleural effusion. Differential diagnosis, pulmonary TB, heart failure, chronic kidney disease, connective tissue disorder, chronic stroke, acute liver failure. Investigations to be done was complete blood count, inflammatory markers like ESR and C-reactive protein, blood gas analysis, chest X-ray, blood culture, urine microscopy, gene expert, sputum test, ECG, echo, LFTs, UECs, antinuclear antibody titers, rheumatoid factors for connective tissue disorder, especially SLE.
Okay, stop. Go back one.
Okay.
Can I ask a question?
Yes, please.
Oh, sorry. Sorry, I joined a bit late. I don't know how did the diagnosis of severe pneumonia come around in this particular patient? What are the criteria for severe pneumonia?
Yeah. Barwakha, one of your lecturers is online. I know that voice. Go back one slide, Barwakha.
Okay.
Okay, so answer Dr. Loving's question.
Okay, for you to diagnose severe pneumonia, you have to have history of cough or difficulty in breathing, and and also one of the danger signs, like if the oxygen saturation is less than 90%, and if the child is cyanosed or inability to drink or breastfeed.
Okay,
and
so what
AVP
Dr. is asking is, this child's respiratory rate was 31, saturations were 96% on room air. So
that was when the child was resolving.
that was at the beginning, Barwakha.
No, not at the beginning. It was when I was clacking. Already the child was almost being discharged.
Okay. Dr. Loving, you want to add on?
So the point we're trying to make is you should give the diagnosis at the point in time when you are clocking the patient. So for example, maybe the child had severe pneumonia and had therefore you correctly defined the criteria for severe pneumonia, but by the time you
I think you're breaking
so
up.
you could say that this is a severe pneumonia initially that is now resolving, and now is this a pneumonia only? So sorry, can you hear me now?
Yeah, you broke up, but I think your point is clear that our colleagues need to mention what we have, when we were at that particular point in time.
Yes, thank you. And again, sorry, I missed the initial presentations. I'm not sure, but I mean, this looks like a very impressive differential diagnosis list. So I know we'll talk about it in the ward rounds, but just coming from a 3-year-old with a cough for a few days, and you have heart failure and chronic kidney disease and connective tissue. I mean, it's a very impressive list there.
And thank you, Dr. Loving. That was actually why I was stopping our colleague. Daktari, if you can, Barwakha, if you can just go to the next slide, please.
Okay.
Now remember, Barwakha, this is not a witch hunter, so we go slowly. So why do you want to do, let's go through each one of these. Why do you want to do the CBC for a child who has allegedly pneumonia? What are you looking for?
I'll check at the white blood cells count and its differentials to rule out bacteria.
So the white cell count will be high and you'll be looking to see a relative neutrophilia. Am I right?
Yeah.
You'd also be interested in the hemoglobin?
Yes, to rule out.
Why?
If the patient is presenting with maybe TB, they will have anemia.
Okay. Are you interested in the platelets?
Yeah, if it is a chronic infection, it will be raised.
Do you think it will be raised in also an acute process maybe?
Yeah, inflammation.
Have you heard of an acute phase reactant? Who, can I have a colleague? What is an acute phase reactant? Colleagues, now you're fearing because Dr. Loving is there. He's not going to ask any more questions. Come, colleagues.
Hi, Doc. I think an active phase reactant, these are inflammatory markers that are elevated during the initial stages of an inflammatory process. So they indirectly show the level or the severity of the inflammation caused by a disease process.
Do you have examples?
Yes, the ones we have, on the screen, the erythrocyte sedimentation rate and the C-reactive protein. Those are the two most common ones, and that we also happen to know.
Okay, platelets are also part of it, Daktari. That's why we are having this conversation. Ferritin levels can also go up whenever you have an infection, and there may be one or two that are missing, and Dr. Loving can add on if you can add on if there are others. So Barwakha,
Yes,
so you
sir.
see, when we are going to ask for investigation, we have to say CBC and then talk about everything else that we'd be interested in a CBC. Now, ESR, your colleagues have helped you, the CRP, they've helped you. But what about procalcitonin? Would you be interested in procalcitonin in this child? Okay, where is Mr. Hanif? Hanif, tell us why. Would you be interested in procalcitonin?
Yeah, I think.
Where is Mr. Hanif?
Look, procalcitonin will help us to differentiate between whether it is a bacterial or a viral.
Okay. Is it an absolutely accurate measure?
No.
Okay. So we'll have to read up on the specificity and sensitivity of some of these tests that we use to diagnose pneumonia and see how relevant they are. So, there are some things, we'll not be able to discuss everything about pneumonia today, but this is something that I would really urge you to read up on. The role of a hemogram in diagnosing pneumonia versus CRP versus ESR versus procalcitonin, because these are tests that you're going to be commonly asking for. And you need to look up and see how important these tests are as against your clinical acumen and your examinational findings and your history of a child with these problems. Now, blood gas analysis, Barwakha, would be only if we are heading to ICU. Would you agree?
Yeah.
So it doesn't feature here in the saturations of 96, you accept?
Yeah.
Because this child has significantly reduced air entry on one side, a chest x-ray is acceptable, correct?
Yes, doc.
Now, this question is for the rest of the team, not you, Barwakha. Is it necessary to do a chest x-ray on all children who you think have pneumonia? Can I hear a fresh voice? Or send me a couple of chats. Let me hear what people think. Chest X-ray for all children. Yes or no? Okay, Fatima, no. No. Omar? Come on, a few more votes, guys. Mr. iPhone, you must really identify yourself. No, indicated Galaxy A12, my friend. That I like that statement. It's only indicated when you think there are complications. You should really put your names. Blood culture, Barwakha?
Yeah, to rule out if there is sepsis, maybe.
Yeah, but blood culture would be important. Just remember that by the time you get this child who's been on so many antibiotics, the chances of you getting a positive blood culture is going to be close to 0, but that doesn't mean that you don't do it, especially in this child who has complicated disease. Urine microscopy, if you think there's generalized sepsis, Barwakha, true. The gene expert and sputum we have spent some time talking about. Why do you want to do an ECG?
To rule out cardiac issues. That's maybe.
You know, Barwakha, an ECG is going to cost your patient 1,000 shillings. It's going to involve a medical worker coming to do an ECG. It's going to take time and effort. Do you really, you've seen all these pneumonias in the world. Do you really feel an ECG is necessary for each one of them? Is that the message to the team today?
Not really. It's just
Okay.
in case there's complications.
I tell you sincerely, Barwakha, I probably never asked for an ECG for any child who has pneumonia. Okay.
Okay.
Yeah, and even complications. Echo, I think, Barwakha, I'll probably have the same comments unless you have gross cardiac findings in a child who is significantly immunosuppressed, who's got multi-organ disease, who you think probably has a pericardial effusion. So this ECG and echo would be rare. Now I'm trembling because Dr. Loving is around. Would you really want to do an LFTs, Barwakha?
Not really, not for this patient.
You know, this effusion that you're going to show us is on the right-hand side, so it touches Dr. Loving's liver. So it may be, he may want to have a few choice words to discuss on that, but we'll wait to see his thoughts. UNCs, I think, are pertinent, but I want somebody else to tell me why UNCs would be important in a child who's hospitalized for pneumonia. And you can send it on the chat box as well, guys. Why is a UNCs important? Let me hear a few quick votes.
Risk of AKI.
Increased of?
There is increased risk for acute kidney injury.
Why? Come back. Who are you? Come back. What's your name? Hey, where have you gone, buddy? Come back. Okay, I like these thoughts. Staph glomerulitis. These children could get dehydrated because they are drinking poorly, sorry. So because of that reason, they're at high risk. What about syndrome of inappropriate ADH secretion, guys? Barwakha, it's a possibility?
Yeah.
Okay, now this anti-nuclear antibodies, you could see our colleagues also a little bit concerned. Remember, this is the first episode of pneumonia in a 3.5-year-old child who's been coughing for about 10 to 12 days, just so that Dr. Loving is also with us as well. So you also, I'm sorry, I'm trying to read. I'm following Dr. Waris's instructions. Now, the thing is this, that you mentioned a child who was growing and thriving well, whose mid-upper arm circumference was good, whose weight was good, Barwakha. So first-time pneumonia, 10 days of duration, I wouldn't necessarily go down connective tissue pathway.
Oh.
But, you know, it's nice that you have talked about it because now we are on red alert for what we can and also cannot do. Next slide, Barwakha.
These are the results for tests that was done for the patient. The complete blood count was white blood cells was 16, which was high. Neutrophils was 61.5, lymphocytes was 22, and inflammatory markers, the ESR was high, and also the C-reactive protein was more than 250, which was high, and gene expert was negative, UECs was normal, chest x-rays, it was, yeah.
Okay, take us to the next slide. Now, don't talk now, Barwakha. Can a colleague agree to volunteer to talk? Barwakha, which is the first and which is the second as we look at this?
Okay, can you see my cursor?
Yes.
This is the first and then this is the second.
Okay, can anybody comment on the first slide, on the X-ray on the left? Is there somebody strong enough and anybody? What about Mohammed, our Zoom host? Mohammed, can I put you on the spot? You tell us what you think about the X-ray on the left.
I can give it a try.
Bismillah.
Okay, so first of all, I think the X-ray to the right is the one that was taken.
You've broken up.
This was the first one, and then this is the second.
Ah, thank you. I also thought it was like that. Yeah. Mohammed, X-ray on the right. Okay, I think his connection is poor. Barwakha, you want to take us through the X-ray on the right?
No, can I try?
Okay.
Yes, please try. Yes. I love volunteers. Who is that? Name yourself. Omar.
Omar Blubat.
Omar, thank you so much for participating today. It has really made it enjoyable to hear your thoughts.
So this is an X-ray of a 3-year-old that was done on 23rd October 2022. When we check on the both sides, there is a, so on the airway. Hello, is it?
Hello.
No, it's not me. Carry on, Omar. Omar, carry on.
Yes.
Sorry, okay, sorry.
Omar, carry on.
Yes, doc. So on the airway, the trachea is not divided at the center, but the division that the carina well, and then
Omar?
on the, yes, doc.
I'm sorry, I'll also be interrupting you. Is this a reportable X-ray?
No, not. It's not good to report this one because of the. There's an aspect of you can say more of an over penetration,
as evidenced by.
Evidenced by there is a loss of the spinous process.
Spinous processes are very hard to tell me about these vertebral bodies. You see, you can see the vertebral bodies all the way down to the end.
It is not clear.
No, it is very clear. Barwakha, you'll have to use your pointer and just highlight the vertebral bodies going down towards the abdomen. Okay.
Oh, yeah, it's clear. It's clear. I can see now.
You can see? So,
yes,
Omar, making a mistake is very important in medicine. It makes sure you never make it again. So, this is actually a slightly over-penetrated X-ray because you can see the vertebral bodies all the way down to the bottom. Okay?
Okay, thank you.
Ideally, you should see them up to the level of the diaphragm there, where Dakhtari's pointer is. Around over there. Go to the midline, Dakhtari, Barwakha, in the middle there. There. So ideally you should see vertebral bodies all the way till there, more or less clearly, but you can see they can see them much clearer even going down. So it's slightly over penetrated. Tell us about the rotation. Is this rotated, yes or no? Barwakha, you'll help us with your pointer every so often.
Yes, it's rotated because of the clavicle.
Okay. I tend to use the anterior ribs. Can you show us the anterior ribs on both sides, Barwakha?
Yes, they're here.
Yeah, come up because you have to compare left versus right.
Okay.
So you see that one on the left versus that one on the right. Beautiful, Barwakha. You're helping us today. See, they're almost equal in length.
Yes.
So it's actually not rotated. The clavicles give you a a strange thought. You see, this child also has a slight scoliosis. Can you see, follow the spine coming down? As you come down, you see there's a bit of a, because this child is splinting because of this effusion on the right-hand side. Okay. Yeah. So it's not a very rotated X-ray. It's almost, it is, and then is it a well-inspired film, Omar? Can you see more than 6 anterior ribs?
Yes, for the anterior ribs, yes.
Okay. So
on the left
with the
side, clear.
Yeah. So with the thought flows that it's a slightly over-penetrated X-ray. Now tell us, Omar, I don't want you to go through complete X-ray reading because that's not going to be the plan for today. But tell me the most obvious thing that you see that you do not like, Omar.
The obvious thing is like the asymmetry in terms of the lungs. On the right side, there is a blunting of the what you call the costophrenic angles.
There is obliteration. There is obliteration. See, it's not even there. You have no clue where it is, isn't it?
Exactly.
So what angles are obliterated here?
We have obliteration of both the costophrenic angle and cardiophrenic angle as well.
Beautiful, beautiful, excellent. What else can you see that you don't like, Omar?
Is there a level of like a mini sky?
Very good, excellent. What else are you seeing? Are you sitting next to a radiologist, you, Omar?
No, doctor. I'm just in
Are you an undergrad student?
Yes, I'm undergrad.
Inshallah, you will do well. What else? Follow the trachea for me, Barwakha.
The trachea, yes.
And then come to the left. Come down, and to the left. You see, you can follow it nicely. Now do the same for the right. So you're struggling somewhere there, yeah?
Yeah.
Can you see the right heart border clearly?
Not clearly.
Right heart border gone, right hemidiaphragm gone. So conclusion.
Is those KDB lines, bro?
No, I don't see any curly B lines. I've never seen them in my life. Don't worry about curly B lines in pediatrics.
Okay.
So what's your conclusion, Omar?
From my conclusion here, I can see there's a pleural effusion on the right side.
To memaliza. Now come to the left. Since we have you, we're just going to carry on. Now, can you see, this is also, do you see the anterior ribs here now, guys? Look at the anterior ribs on the left versus the right. So you can see they are much, much longer on the left than on the right. Barwakha, where's your wonderful pointer, my dear?
Here.
Buonazione.
Hawani.
Okay, no, I want it on the X-ray on the left, my dear.
From up or down?
My dear, I want it on the other X-ray. Tumemaliza hiyo sasa.
Okay.
Now, draw me the anterior rib on the left versus the right and show us that it's much longer on the left. And come down. You see the length of that, Barwakha, versus the one on the contralateral side. And look at several of them. You can see they are much longer on the left.
Yeah.
So you see in this is now this one is now a rotated X-ray. Even the penetration is still slightly over penetrated because you can see all the hemidiaphragms, shame on me, all the vertebral bodies coming down. Okay.
Yeah.
It's in good inspiration. Sawa. But you see, this is also slightly rotated. Now, just for the sake of time, you can see a clearing of the effusion, true, on the right-hand side. And you're starting to see the right heart border much clearer than on the previous X-ray. Thank you, Barwakha. Lovely. And you're starting to get the hint of a cardiophrenic angle happening over there. But you still can't see the costophrenic angle later on. Sawa. And I think that's the important thing. So here we're seeing what appears to be a resolution of disease. You can actually see the horizontal fissure. I don't know if people can see it. Barwakha, can you bring your pointer, my dear? Can you see that horizontal fissure on the right-hand side? Come on the right-hand side. Bring your cursor down a little bit. Down, down. There. Up. Up a bit. Go slowly. Up. A bit more. A bit more. Stop. Stop. Come down. There.
Yeah, yeah,
Yeah. So that is fluid in the fissure, isn't it?
yeah.
And if you follow it to the lateral, go to the left-hand side, Barwakha, the other side, and stop there. Yeah. Come back up to where the horizontal fissure was. Yeah, over there. Now that is fluid that is still remnant within the pleural space over there. You're doing, Barwakha, you're doing so well. Can you come to this X-ray on the right-hand side, please? Colleagues are following. I hope we're not losing each other. Come, go up just a little bit. Yeah. And to the right-hand side, Kidogo too, just like a centimeter. No, you're in the wrong place. I wanted to show you the lamellar sign where you actually see the visceral pleura is lifted off. Yeah, over there. Can you see the hint of the pleura? Just, yeah, there and then up there. I don't know if it's clear, but there the visceral pleura has lifted off the parietal pleura. If it's not clear when we're doing a ward round on Thursday, inshallah, we'll talk about it. Are there questions on these X-rays before we move to the next slide, colleagues?
Yes, sir.
Go
Is
ahead.
the heart shadow normal?
Barwakha, heart shadow, is it normal? Which X-ray? Are you talking about the first or the second?
One which is clearing, the second one. Is that one?
It's normal.
It looks normal to me.
Yeah.
Okay.
Yeah. Any other questions on the X-rays? Okay, Barwakha, move to the next slide, my dear. Scoliosis. No, the scoliosis, Mr. Eisenmenger, is
Hello, Doc.
is apparent. It's not Wassam. It's not real scoliosis. It's because the child is splinting towards that side to reduce the pain secondary to stretching of the pleura. Now here, Barwakha, we can't do a CT scan conversation. What I want you to do is use your pointer and show the colleagues where the effusion is on the right-hand side. Where is your... Huh?
The pointer is here.
Okay, so you want me to help you?
Yes, please.
Okay. Go up to the block there and... Okay, sorry, my dear. Come to the middle ones.
Okay, there's
Okay,
one.
there. Okay. Now the one on the right. Well, man, now
Okay.
to the left. I want you to come to the middle one. Sorry,
This
Barwakha.
one.
No, my
Bottom
sister.
part or?
Come back up there. Now, wait, stop. Yeah. Now go up. Just only one up. Yeah. Now we're going to stay on this slide. This is the only one I want us to work with today. Okay, don't leave that. Leave your pointer where it is. Now,
Okay.
dear colleague, leave your pointer. Now, dear colleagues, if you look at this CT scan, remember when you're looking at it, what's on the left-hand side is actually the right. So if you look at the bottom, you'll see this little haze of gray that is on the right-hand side. And that is the effusion that is on the posterior level, because you see the child is lying down supine. Barwakha, you think you can point it out? You think you're there? Yeah. Now go to the hemithorax, the other side. Yeah, there. Come down a little bit too. There we are. Now that is the effusion, guys. You see the effusion is going to be in the gutter, in the paravertebral gutter. So that's the effusion. Sawa people, take me to the next slide.
Management. For
Okay.
severe.
I think I'm going to, can I take over, Barwakha, in essence of time and people's issues?
Yes.
So here, what we are showing is a patient who really came in with complications. It was not just a simple pneumonia, but sometimes it's important to talk about complex things because then you understand simpler things a little bit easier. So oxygen, IV fluids, we have talked about the choice of antibiotics today. Non-severe pneumonia, we've talked about the amoxicillin. And just remember that when you're dealing with a child who has a pleural effusion, we remember that you have to put in a drain and drain every drop. Now, this is very, very important, colleagues. When you have water, pleural fluid in the pleural space, you must remove every single drop. So when you go in and you're doing a diagnostic tap, you're also going to do a therapeutic tap, and you're going to remove every single drop that's there. And that is very important. Next slide, Dr. Ari.
I'm done. It's the end.
You're done. So now, my colleagues, time might be against us, but our colleague Nabila is going to be presenting. We'll let you know when, but she's going to be presenting on management of pneumonia. So we're going to jump into it in a little bit more depth. Today it was just to talk about a case. Do you have questions on today's presentation? And before I also leave you guys, we have this Telegram group to which a large number of you have come. Please spread it to the rest of your colleagues. The beauty about a Telegram group is that you can join and go up and see what people have talked about in the past and learn from it. And the more active you are and the more engaging you are on the Telegram group, the more engaging I will be with you. And I think those are the pertinent points I wanted to ask. So now, are there general questions that people have that are important before we close?
Yes, Doc. What's your comment on the last text from Dr. Lavin?
Oh, I didn't read it. There was so. What did he say? I didn't.
Consider a separate session on X-ray interpretation with Dr. Waris.
Inshallah, if you guys agitate and you want, it will happen. Bi'idhnillah.
Inshallah. Assalamu alaikum, Doc.
Salam, tell me.
Assalamu alaikum, Doc.
Wa alaikum salam, tell me.
This is Dr. Muta.
Yes.
I'm interested to understand how you went all the way to investigating with a CT scan chest. What was missed? What was the worry? And could treatment have been done without the CT chest?
Yeah, very, very important question, Dr. Ari. Thank you for asking. Look, first of all, I was not the one managing this patient, number one. Number two, I am in total agreement with you that if you have a child who has an effusion, the child is definitely going to need a chest X-ray for you to even start that blood flow process. But what is going to be important is also to do a chest ultrasound. Chest ultrasound, put in a drain every drop, investigate it appropriately for the possibilities of a viral, bacterial, mycoplasmal, fungal, or oncological process, because that is what is common in our community. I would then carry on with serial chest ultrasounds for this patient to ensure that the child is getting better. So I wouldn't have done the CT scan myself because, as you can see, and I'm in agreement with you, it did not make a difference to the overall management of this child. We are not here to say that I wasn't part of the team. We are here to take collective responsibility, as is the tariqah of our deen. So we speak as one, and we take responsibility as a whole and as a team. So I love your thoughts. They make a lot of sense to me. I wouldn't have done the CT scan. I'm in total agreement with that.
Thank you.
Another thought? Amin. Any other comments? Okay. Mohammed, I think there'll always be questions on pneumonia, but I think it's a fair time to stop. Would you be okay with that, my brother?
Hello? Yes. Okay. We've really come towards the end of time. And I really want to appreciate you, Dr. for agreeing to come and mentor us around this topic. And inshallah, we have really enjoyed, and I'm sure the members are very much appreciative of your making time. And also, I really also want to thank our our lecturer, Dr. Loving, for joining in, and all the other senior colleagues. Thank you so much. We don't take this for granted. We'll be, inshallah, engaging you for more learning sessions and, inshallah, even better programs. At this point, because of Isha and time, I want to say good night to everyone. Inshallah, we'll continue from next week on the topic discussion on pneumonia. Thank you so much, everyone.